Welcome everyone to today's webinar, The Paradox of Virtual Care, How Monitoring from Afar Can Improve Care at the Bedside. I'm Aaliyah with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. We will have an audience polling question during today's webinar. When we reach the poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. We will also have a short survey during today's webinar. Please take the time to fill this out before the webinar ends. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link used to log in to today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Adam Seaver serves as Chief Medical Officer for Monitoring and Analytics and Therapeutic Care Business Groups of Philips Healthcare, with responsibility for medical direction of respiratory emergency care and monitoring solutions. Prior to his role at Philips, Dr. Seaver practiced trauma surgery and surgical intensive care for 20 years on the faculty of the Department of Surgery at Stanford Medical School in Palo Alto, California. His research has focused on computer applications to critical care, emphasizing mathematical modeling and decision support. Dr. Ashok Palagriri, Medical Director, Mercy Virtual, including VICU and V-Sepsis, is board certified in critical care medicine and neurocritical care. He has served in many capacities at Mercy, including critical care fellowship education, peer review, quality improvement, sepsis care, and workflow pathway optimization. He is currently co-leading the Mercy Ministry-wide Sepsis Task Force, is a member of the Critical Care Specialty Council, and serves on the Philips Telemedicine Advisory Board. Dr. Palagriri has been working with Mercy Virtual since the initial inception of Mercy SafeWatch in 2006. At this time, I am pleased to turn the floor over to Dr. Seaver to begin today's presentation.
Thank you, Aaliyah, and thanks to the Becker's team and to everyone joining in on the webinar this morning. We are certainly delighted to bring you this engaging and informative webinar with one of our key Philips customers. Mercy Virtual has been a partner of Philips for over a decade, and as you will see, they are a true innovator in the area of virtual care. You'll see they have a lot of insights and experience to share, and so let's get to it. And with that, let me turn it over to you, Dr. Palagriri.
Thanks, Dr. Seaver. Thanks, everyone, for joining. It's great to see that there's such an immense amount of interest around virtual care. Just looking at the list of attendees, for me, that brings great solace to know that there are many like minds out there that know that we have to head in this direction of bringing telehealth to our patients and families that we serve. So a little bit about the title of this, Paradox of Virtual Care, How Monitoring from Afar Can Improve Care at the Bedside. I will tell you, as I've looked at that slide, one thing that we should all be cognizant of is the term monitoring. What we really probably now thinking about it, should have changed it to, is how partnering from afar can improve care at the bedside. So when we talk about virtual care, we need to break the stigma that we are two separate entities and become one with the bedside. And as we go through these slides, I'll speak to that and try to impress upon everyone, if you are beginning your journey into telehealth, these are some areas where you can focus on to improve the outcomes and the partnership. And those of you that are already in the telehealth space probably already know that getting that partnership is probably key to success.
So Dr. Palagriri, as you think about Mercy Virtual's approach, I wonder if you could mention what you think is unique about it and whether you think the approach is sustainable.
Sure. Thanks, Dr. Seaver. Here at Mercy Virtual, we started our process from the health system perspective. So Mercy as a ministry, in my opinion, had the forethought and the early mindset to think that, the future is going to be here soon. We're headed to EMRs. We need to improve the care that we're delivering to our patients. Telehealth back in 2006 was just starting. I think there were a few sites that came before us in 2001. So for us, we are driving our processes from a health system perspective. We are driven by clinicians, myself and other medical directors, along with intensive care nurses and medical nurses that really bring the focus of telehealth from a clinical perspective. If we see the difference between different telehealth platforms out there, I feel that our premise, our difference is that the health system perspective allows us to be better partners when we line up with other sites. Now, is it sustainable? Double-edged question there. I would say yes, it is sustainable, but one of the reasons is it has to be sustainable. If you look at the current state of healthcare, if you look at how hard it is to retain physicians and nurses at the bedside, the turnover rate, a lot of this is secondary to just the sheer amount of work that needs to be done and not enough resources. So we have to find a better way to reduce the burden of work on the bedside caregivers in a very partnership type way so that they feel rewarded when they come to work and that they know that they have a help from afar, which is that telehealth perspective that we'll be talking about here shortly. A little bit for everyone on, sorry. Go ahead, Dr. Seaver.
No, go on. I'm sorry.
Okay. Just for everyone on the call, I wanted to just speak a little bit about what Mercy Virtual Care Center is. We are an entity that in 2015, Mercy built a building so that we could house multiple telehealth strategies. Here at Mercy Virtual Care, we have over 950 coworkers. I'll show you in a few slides the 13 different solutions, ranging from at-home to in-hospital to telemonitoring services. Utilizing both the virtual ICU, virtual hospitalist, and our care management services, we're in over 40 hospitals in 7 different states.
So Dr. Palagiri, when you think about all the different hospitals that you're serving and the various services that you provide, I wonder if you could comment as to which of these you think receive the greatest benefit.
Sure. As we've made our journey since 2006, we have had the opportunity to work with a variety of facility types, ranging from rural, tiny, small hospitals, critical access hospitals, medium-sized to large academic centers. I believe all facilities can benefit from telehealth. I believe, though, it's not a one-size-solution-fits-all. If we speak to the larger academic centers, they typically already have 24/7 resources, physicians, house staff, APNs that are able to provide care to their patients. But they also are stretched thin. There is a dichotomy in every facility, whether it's a large, fully resourced and staffed facility to a small facility, in the sense that we do have a difference between daytime critical care and nighttime critical care. Part of what our goal here at Mercy Virtual is to get rid of that dichotomy and provide patients a 24/7 continuous critical care coverage scheme in which we hand off efficiently and we also give the patients the same care, whether it's 8 a.m., 8 p.m., 2 a.m. When I look at large academic facilities or even large centers with 24/7 coverage, we should find ways in which they can leverage us to complete tasks or improve quality measures that they may be struggling with. Versus a medium-sized facility or small-sized facility, they truly will benefit from the added layer of a telehealth service, tele-ICU service, with nurses to help monitor, with physicians to possibly perform daily rounds on critical care patients if there are no intensivists there, and definitively with providing nighttime critical care coverage. My stance, being an intensivist, is that any patient in an ICU deserves an intensivist or an advanced practice provider that is trained in critical care to be managing their care. From a tele-ICU perspective, what we have shown on our PAT since 2006 is that we are able to break down those barriers of allowing nighttime nurses at the bedside to feel comfortable connecting with a virtual intensivist at any time, as many times as they need to throughout the night. Here, briefly, for those of you that can see on this slide, I just want to show how we have moved from when we started in 2006. I began with actually Mercy St. Louis in 2006, so I was a staff virtual intensivist for 2006 till about 2014 when I moved into the medical director role. As we moved along from 2006 to about 2008, 2009, we started small at Mercy, doing a couple of ministry hospitals at a time and getting them into the tele-ICU arena. Back then, EMRs were not as robust as they are now. We were able to leverage utilizing the Philips platform to bring to the bedside better visibility of their patients and alerts and acuity. And as we are moving forward now into 2018, 2019, we are able to integrate all of what the EMR has to offer and what Philips has to offer in order to provide sites with better care for their patients in real time. As we moved along from 2006, we did start thinking about better ways in which to utilize virtual care. The stroke program came about. The sepsis we started back in 2011, and more recently in the last 12 months have revamped it and have seen dramatic results. The engagement, where we feel that we need to start providing care that centers revolves around the patient. It cannot be just in the ICU. And what we have noticed in virtual ICU is if we don't have the visibility before they come into the ICU and after they leave the ICU, then we really are only a spot weld type solution, and we need to follow that patient from home to hospital and back to home and everywhere in between. Follow them in the ED, follow them on the hospital floors, follow them in the SNFs. So that, I'll hand it back over to you, Dr. Seaver.
Yeah, I think we'll now move on to trying to get some feedback from our audience and move on to our poll question.
All right.
Yeah, so the poll question, I'll read this and give you some time to answer it, but it has to do with what obstacles do you anticipate would prevent your health system from executing on telehealth and virtual care? And there's 3 items to consider. One would be budgets, lack of available money. Second would be culture, resistance to change. And third would be physician engagement, willingness to adopt new ways of working and providing patient care. So if you could click on the item that relates to your assessment, we should be able to get some feedback. So it's pretty interesting. Is a division among all 3 items. Looks like physician engagement, willingness to adopt new ways of providing patient care is the leader, followed reasonably closely by budgets. And then the third thing is culture, resistance to change. Well, that's very interesting. because I think that as Dr. Palagiri continues, might cast some of this information in a new light. So with that, let's go on to turn it back to you about your lessons and experience, Dr. Palagiri.
All right. Thanks, Dr. Seaver. So as I was preparing for this webinar, I sat and went back to 2006 in my brain and wanted to think of all the hurdles and roadblocks that we have encountered and developed strategies to improve the way in which we can deliver the care and partner with facilities. I came up with 8. I'm sure there's more than this. I will say to those that are on the call, those of you that are already in the telehealth arena, tele-ICU arena, all of this will ring true to what you have gone through. For those that are about to embark on it, I don't want this to scare anyone. I think if you were to ask me, would I do this all over again every day I wake up, the answer is yes. It's very rewarding to be able to help patients and caregivers and providers provide excellent care to their patients and the families that they serve. And I believe that this, like I said earlier, this is not a should we be doing it? It is we need to be doing it, and how do we do it? And hopefully with all of you on the call, and once we start connecting, we can come up with better strategies to make it financially feasible and also maybe change the ability for most of the U.S. to achieve getting telehealth to their patients. So what we'll do is I'll go through these 8 different topics. I have a little bit of feedback on each one. So let's start with culture eat strategy. Most of you know this just from working in medicine. Well laid out plans when done in a boardroom or done behind closed walls can completely fail if we are not clear about the audience in which we are sending that message to. What we have found is, to no fault of their own, the physicians and nurses and providers at the facilities where we take care of patients and try to partner with, they have their own struggles. They are busy. They have lots of work to do. They have lots of patients to see. And if not explained correctly and not given them the opportunity to say, yes, we buy into this and we see how we can benefit from this, we will always hit a wall in which we are unable to improve the processes and provide good care to those patients because we have not partnered with those sites. And when I mean partner, it's really the ground level. We a lot of times have many discussions on a C-suite level or when we are trying to engage with other systems, with tele-ICU or even other telehealth programs. But when we get running with the program, we start realizing that many people may not have heard about it. Many people don't understand why are we doing it. So what we found is will be very helpful to be successful is you need to assess the facility's readiness for accepting of virtual assistants and virtual partners. And I think when you all answer that poll question, that is part of it, the ability for the physicians to engage and be willing to accept a different process. We have started doing what's called fit testing with surveys to the bedside, both the nurses and physicians, to get a better feel for do we need to spend more time going and speaking with them and encourage them to tell us what are their problem pain points. Let them be the ones that help drive how we develop workflows. I think at a high level, the strategy will always be sound, but at the bedside level, we will start having issues if we don't get the buy-in. Another big thing to understand, and this is all over the medical literature and news, is that burnout is real. Burnout for nurses, burnout for physicians. So what we've been trying to impart on facilities and systems is that when you add virtual ICU or virtual care, it's not a replacement. It is actually a necessity for the physicians and nurses that are working to do their job better.
Thanks, Dr. Palagiri. I have a question that comes up. When you do these surveys to check for fitness, have you been finding that there's a generational impact? that say if you look at physicians who are over 55 and you compare them to physicians who are less than 40, that there's a different attitude and receptivity towards this, whether it be technology or just a new way of working?
I would have to say it's 50-50. Initially, I would have said yes, that the younger physicians are more adept at accepting new technology. At the same time, they haven't been working in the arena long enough to understand how busy it's going to get, and after 5 to 10 years that doing nights or being on call for 24 hours is not feasible. So on one end, they are very good at utilizing the technology. On the other end, they probably don't know enough yet to know that having the backup or having a nighttime virtual partner or even a daytime virtual partner to help them get the tasks and care done is beneficial. And on the other end, the older physicians that have been around long enough, sometimes, myself included, we can be stuck in our own ways, and this is how I take care of my patients. So it's always hard to accept another group of physicians or nurses coming in and possibly suggesting different ways. So part of all of that is for us to just do a really good job of explaining that we are their partners. We are not an external entity trying to point out faults. We're only there to all revolve around the patient and provide excellent care.
Thank you.
The next part goes along with how do we prevent culture from eating our strategy, and that is communication, communication, communication. Starting in 2006, really all we had was one medical director and one ops director, and they did road trips and they went and talked to facilities, starting at the C-suite level and then down to the ground level. And even that was not enough, because you will always miss someone. You will miss a key person. You can send emails, but people are not going to read the emails. You can set up meetings, but people won't attend those meetings either. So that's not to scare anyone, but it's to say you need to have a multifaceted strategy of newsletters, tip sheets, emails, face-to-face meetings, webinars. All of those are what you need so that you make sure you touch and talk to every single person that will be encountering your telehealth service. We've noticed that typically in the tele-ICU arena, it's a very nighttime heavy utilization. So therefore, daytime nurses and physicians aren't really clear as to what it's there for. And when families ask them, they may get the wrong impression that, oh, I'm not sure what that's here for. So by partnering, by communicating, even facilities that may not be using the service during the daytime, they can speak to it as they know that during the night that they're getting the service that the patients need.
So any tricks that you'd like to share about how you can get engagement from, say, the busy medical staff of facilities that you serve to participate in either more general communication? And then I'd also be interested in whether you think that there's a role for tools, technology that can enhance the communication with the bedside in the real time of caring for the patient virtually.
Yeah, our tips, since we've been able to grow significantly from 2006, is we have layers that help reach the providers at the bedside. We have a business development team that starts the ball rolling and gets in touch with the facility and their personnel. We have an implementation team that also spends a significant amount of time with multiple meetings throughout the weeks going up to a go live. And then we have our clinical team where personally what I will do is reach out to those physicians, find the time that is most amenable to them to connect. Ease of communication is the way it needs to be. Not many people are going to have time to get on the phone calls, so if you can do it through emails, sometimes just texting back and forth so that they can give you their impressions is what helps. Dr. Steve, you tell me the last part of your question?
Oh, just in terms of technology that you may be using for communication.
Yeah, one thing that we built when we first started back in 2006, when we connected with the bedside, it would be a phone call with a little post-it note that got put on your desk as a virtual provider. We've now moved to making everything electronic. We've embedded it into some EMRs so that the physicians and nurses can connect with us through the patient's chart, so we get the information and we're right patient, right time. What we've noticed is that the engagement with the bedside increases dramatically if there isn't a barrier to putting a phone call and giving metrics and data. I will tell you for the physicians, I think secure chat, which is coming to most entities, is probably going to be a game changer where they can easily connect with us and we can communicate back and forth and not take people away from either their work during the daytime or their family life when they get home. Because handoff is very important for those of you that are entering into the telehealth, tele-ICU world. Without that engagement with the bedside and the handoff from the providers that you're going to be providing care for, then you start working in parallel instead of in series.
Interesting.
Okay. Next thing that I have here is with growth comes new challenges. We learned that through our journey. Most of you that are going to be starting, you may get 75 or 100 beds when you start out with, and that is a very manageable amount, even up to 150 beds, where it's easy to staff. You may only need 2 virtual nurses and 1 virtual physician. You may not even need a virtual physician 24/7, depending on the sites that you're taking care of. But if you're successful and those sites start spreading the word that you are providing a quality service, you will easily and quickly move up to 200 to 300 beds. One thing that happens here is that staffing can start to become difficult. So the truth is, bedside staffing is difficult as it is. So when you try to do virtual staffing, you're going to run into the same problems. And if you're in the same vicinity of the sites that you are serving, you don't want to steal away personnel to staff them. So you kind of have to work together on that. And then at 200 to 300 beds, your cost starts going up. What we realize, though, is once you get past those 300 beds, it is a completely different process. You need to create much more robust policies and automation of tasks. You have to have a very robust data monitoring system and metric system, and then you now have a lot more employees that you are having to manage than the small initial shop that you had. I think part of our success comes from the slow growth that we had and the foresight of Mercy as a ministry to provide us this virtual care center and the staff and the resources with business development, data metrics team. We have an IT team. I think that's, as you grow, you should probably plan for that unless it's just a small fixed shop of just kind of using telehealth for 1 or 2 hospitals.
That's great. I wonder if you could talk about, in terms of qualifications for your nursing staff and your physician staff, does that somehow contribute to or impede your ability to grow the way you've described?
No, we are initially when we started back in 2006, we wanted to get more senior nurses that had been at the bedside for at least 5 years. That way we could provide the mentorship. As you grow and as the tele-ICU, actually the ICU nursing arena has changed, no longer are you unfortunately going to be able to find those senior nurses. So what you have to start working on is a way in which to train nurses and physicians to be virtual. For our physicians, we've always held the standard that they have to be critical care board certified. Some of them have additional board certifications. For our nurses, they are all CCRN-E trained. We make that a requirement within, I believe, that 1 or 2 years of them joining. So we always want to keep that standard so that we are providing the best service to the bedside. That goes
like
into my next.
Yeah, I was going to say it goes into your next bullet there.
Yeah. This is one thing that we realized actually probably in the last 2 years. When we started in 2006, we really didn't know what it meant to be virtual, except that we wanted to help the bedside. But we were taking bedside clinicians and bedside nurses and asking them to help other clinicians and nurses from afar, and we were being very duplicative in what we were doing. Our aha moment was that if we are true partners, we need to trust that the bedside nurses and physicians are aware of what they're doing and know when to ask for help. Therefore, we're not being redundant when not needed, yet we can all agree that some of these extremely sick patients do deserve multiple sets of eyes in the first 6 hours of admission. So what we realize is, for those of you that are starting this arena, it's going to be hard to train nurses and physicians to be virtual providers if you're not sure of it or you've never done it before. We are working more on robust telepresence training. Those that have worked in the hospital know that not all physicians are made the same. Some of us have good bedside manner, some of us don't have good bedside manner, and that all, when you're in the telehealth arena, you have to be able to come across that camera consistently and in a very appropriate manner so that you're always there to help. You are never seen as a barrier to providing care. So that was just one big point I wanted to impress upon those that are starting their journey is you may want to spend some time on figuring out a good training program for the first couple of months of the new hires that you have to make them understand what does it mean, what is their job going to entail. Are they just supposed to be doing the same things that the bedside nurse and physicians are doing, or are they supposed to accentuate it?
So, Dr. Pellegrini, do you do training on like phone etiquette or those sorts of things?
Yes. Now in our large virtual care center, we do have a training room in which we do telepresence training, phone etiquette training. We are a call center now too, so we have to be very appropriate when we're answering the phone to understand that when an ICU nurse or physician is calling, they're usually calling for something important, and we have to be mindful that keeping them on the line to collect a couple of pieces of data may not be in everyone's best interest. But yeah, we have an educational department here that's been working on strategizing around ongoing continuous quality training for our physicians and nurses.
Interesting.
Okay. For those that have been in this arena and those that are about to go in this arena, this is where I'm actually very proud of my coworkers and team here at Mercy. And I want to attribute part of that to just part of Mercy's mission and values. And what I'm talking about here is that the virtual team has to always take the higher road. We need to be cognizant that we are getting into a place where the stress level is very high, especially in VICU. And although we are trying to offer help, we potentially are stepping into a situation where adrenaline is running high. The physicians and nurses feel that we may be interfering, and everyone will have those stories if they've been in this long enough where cameras have been broken, balloons or gloves have been placed on a camera, backs have been turned. I think what we have to do is always remind ourselves to be a little bit of a better person and realize that it's more due to the stress of the situation and not due to intention. Very rarely is it, and that we need to reach out and find better ways in which we can be involved. And part of that goes back to our communication. I think if it is very apparent to the bedside nurses and physicians when we're going to intervene, when they're going to see us on the camera, how do the cameras work, how easy can we tell each other, I've got this, or, yep, please go ahead and help me, that will improve the care that's being given. We always want to engage earlier with the site. So once we go live with the facility, we try to have multiple meetings the first couple of weeks so that we can after every shift, identify, was there an issue? Is there a need to improve? Do I need to educate my staff to be better at certain things? Is there a way that we can find out what is causing problems or irking people at the bedside?
So, Dr. Palagiri, I think you make a very good point that it's sort of the softer interpersonal skills that are really paramount on a day-to-day basis. But, for example, if you have a disruptive physician or another disruptive clinician that's just not getting with the program, what sort of formal governance do you have in place that allows you to sort of manage those sorts of situations?
Usually what we do is before we go live, we talk about an escalation strategy with the medical directors and nursing directors. We utilize our own reporting system if we run into issues, but we also engage in the facilities reporting system, in one in which that we all agree before we go live that we want to be aware of these issues and that we want to work through them and find out why are they happening, not to point fingers, not to put anyone in a position to be in trouble. But as we all have worked in healthcare, it's typically not just a one-off when there is a disruptive clinician. It's probably been occurring elsewhere, and it probably will just come to light. But at the end of the day, if you are in the virtual arena, you're a partner, so we should be looking for solutions and not just complaint department, if that makes sense.
Yeah, that makes a lot of sense.
The next bullet point that I came up is, I think you all spoke to it on the poll, and one of that is budget and restraints and how do we show our value. When I thought about this, there are three entities that the value needs to be shown for. We need to show value for the patient. We need to show value for the providers, both the nurses and physicians, and then there's the value for the organization. In my opinion, and part of what we strive for here at Mercy is that the patient is where the care is centered around. So value for them is decreasing mistakes that may happen at the bedside by providing quality reviews, making sure best practices are getting done. These are things such as daily goal sheets, stress ulcer prophylaxis, vent bundles, and then how do we assist them with the care. As recently as last week, we had one of our nurses doing their routine rounds in the virtual ICU, identify a patient that weighed 250 pounds but was about to get a heparin dosing for a 600-pound patient because the weight was entered incorrectly into the EMR. Now, that's the type of mistake that a patient should never see. We do hear about that in the news, and if we can come up with a robust way to make the technology work for us instead of, even for my nurse to have to look through that as opposed to getting alert that there's a potential error that's about to occur, I think that's where we need to move to. But the value for the patient is always going to be that their care is continuous. If they're in the ICU, that they're receiving 24/7 continuous care. And I'll stress this again, and where I've seen our success in facilities is where the physicians and nurses that work during the daytime and nighttime are very much involved in continuing the care that they can deliver during the daytime and nighttime by utilizing the virtual services. And in those sites that do not have intensivists, we have found great success in rounding with the hospitalists on the ICU patients that they may not feel as comfortable as the vented patients, helping them remove these patients from the ventilator in a timely fashion. So I think in those areas where we are able to break down the barriers and provide this coverage, the patients do see a great benefit. The next value is going to come for the providers. One of the benefits I have had is that not only did I work in the virtual ICU, when I first started, it was 8 to 10 weeks of nights a year because I was one of 3 low men on the totem pole. But also as medical director, I still work at one of our facilities where I hand off to virtual ICU when I do my clinical weeks. I can't tell you how much relief there is to be able to go home, sleep at night, and know that I have a strong team of virtual nurses and physicians that are using technology to monitor my patients, and that my night nurses actually can call 5 times, 500 times, and they will get the same care from the physicians in the virtual ICU. For those that are in the hospital, providers can now focus on admissions. As health systems are looking at areas in which we can improve quality metrics, ensuring best practices are being done is always at the forefront. The issue is if you are a physician or APN admitting a patient at night, you are still going to get the additional 40 to 50 phone calls of cross coverage on patients that you are not aware about, and you therefore do not have what I call sterile time for the admission. You need to focus on that patient and what needs to be done with that patient. But if your pager and your cell phone are going off because nurses have only you to go to for questions and concerns, then that patient that you admit will not be getting the same care that they should. The other issue with providers is by providing a more robust backup system / reducing the burden of work, you will be able to retain and even attract physicians and APNs to rural areas, smaller facilities. One thing that we have done, we have 2 centers here at Mercy that are ECMO referral centers, and so using the virtual ICU in some of our smaller facilities, it has been a great use case for the hospitalist to have an intensivist to review these patients and help get them transferred for early ECMO. From an organizational standpoint, one thing that we've done, and it has come about from being in the arena since 2006, is develop a program in which we can help the entire ministry on a directive, and that is our virtual sepsis program. In the last 12 months, by working with technology, we've been able to not just do the virtual ICU, because we realize that ICU is where the patients end up and not where they develop the sepsis, but in the ED and the floors in the ICU. We've gone from a ministry average of 29% CMS bundle compliance on sepsis up into the 55 to 60% in 12 months. Now, I think that's where you start to show the organization that there's value in providing a centralized process for driving outcomes. Now, I will tell you that was not an easy road, even with those 12 months, even though the technology made it much easier for us. We get back to communication. We get back to culture eats strategy. This required multiple meetings, meeting with ED physicians and nurses, hospitalist physicians, bedside nurses, and getting everyone to realize that from the virtual perspective, we are not trying to point out faults, but we are trying to help people get their work done. Sepsis is one of those great things where they showed, I believe it's about over 100, maybe 150 tasks per patient that need to be done in order to get them compliant on these bundles. And there's no way that bedside providers and nurses can get that done alone.
So Dr. Palagiri, you're from the Show Me State, so I assume you get asked for metrics. And I'm wondering if you could comment. I mean, you've mentioned a few about sepsis and so forth, but I wonder if you could talk about your experience in developing metrics, what are better for executives and what are better for clinical leadership, and what are the ones that you found most influential?
Sure. Just to explain to those that are new to the tele-ICU arena, one of the standards, and you can see on this slide, most virtual ICUs will talk about Apache metrics. That's, in a sense, the gold standard of looking at your ICU patient population and determining if clinically you are performing as expected, better than expected, or worse than predicted. The issue that we have been running into is that is just a clinical metric for an ICU physician and nursing team to know that they are doing right by their patient clinically. In the state that we are in the U.S. with healthcare, finance is going to drive most of what you are doing. So what we've been focusing in addition to that is those entities that are driving up the cost. Length of stay in the ICU, length of stay on ventilators, We're trying to tap into how to assist facilities with identifying those patients that are outside of the geometric mean length of stay. That is the one metric that seems to be very problematic. Is there are certain population of patients that you may do great in the ICU and get them out of the ICU, but they still stay in the hospital for longer than what their DRG predicts. And so our goal as we're moving forward is to utilize the technology both with Philips and with the EMRs to not just do care for the entire ICU, but maybe track these patients before and after and start identifying whether they need higher levels of care or lower levels of care. This goes to where we are poised to be a little bit unique here at Mercy Virtual in that if allowed, we can envelop virtual hospice, virtual ICU, and virtual engagement at home to help drive these patients to stay out of the hospital. We also have a virtual emergency medicine program that is starting to treat patients at home to prevent them from showing up to the ED. But I think if we can assist the bedside caregivers to reduce their work, get these patients out, identify those patients that are at low risk for readmission, these are all entities that are going to help the health system be more financially sustainable. Another thing that we are embarking upon is, and I believe there's a couple of other telehealth systems that have done this. I believe Baptist down in Florida I believe they're already doing this, and that is being a regional transfer center. I just got off the phone call yesterday, and I think one of our facilities for the year, it's about $2 million that are lost because patients are being sent to other facilities. So when you have this infrastructure with a tele-ICU or telehealth program, you can start being the glue that holds the system together and utilize your personnel for more than just tele-ICU coverage. So our plan is to do that. That's what we did with tele-sepsis, is to house it centrally and drive the processes across, I believe it's over 3,000 beds that we are covering. This kind of goes into what I have next on here, and that is how, as a telehealth system, you need to develop data collection and reporting strategies early. You're only as good as the data that you can provide to the bedside as to what are you doing in your 12-hour shift or 24-hour shifts. How many notes have you written? How many orders have you written? What types of orders have you written? This also helps us improve engagement from the bedside. If we are noticing that we are not being utilized, but there are significantly ill patients in the unit, we can get back to those physicians and nurses and try to find out where the barriers are and try to improve that engagement. We're not looking for people to just call for simple electrolyte replacements, but the more comfortable they are with utilizing the virtual ICU service, then the more involved the patient gets with the care, and we can improve those metrics. If we don't have a mechanism to show what the virtual team is doing, it's going to go unnoticed. And then you start showing the ICUs what we as partners have done, how we've reduced CAUTIs and CLABSIs, how we've reduced length of stay, and then that will be championed by nurses and physicians at the bedside.
Very clear.
Okay. The last part here, and this has been an ongoing work for us, and that is to make technology work for you and not the other way around. What you will find when you are in the telehealth arena and the tele-ICU arena, you can either have a very tasky nature of sifting through electronic medical records and systems to identify patients that may need help versus creating a system in which those things are brought to your attention. There's a lot of companies out there. When I looked at the list of attendees here, I believe many are probably listening in. We need to work at a way in which we can make the job of physicians and nurses, whether it's at the bedside or in the virtual realm, easier and more pointed in the direction of providing the care, not digging to find out whether I should provide the care. This is where AI, big data is all heading towards. But I will tell you, I don't know if we've tapped it yet in order to determine, do we still have to identify issues with all the data that comes through to us, which makes our job more difficult, or can we build it in to be as intelligent as we are at the bedside to provide the best care? In virtual care, what we found is that initially when you start, you will have a very tasky nature for your nurses and physicians where they may not feel that they are providing care. So anything you can do to reduce clicking just for the sake of clicking and actually taking care of patients will be of much benefit to your staff. The other thing is to make sure you build your interfaces well in the beginning. You don't want to find out after a couple of years that, oh, it would have been good if we had this data. And part of that is just sitting and talking with the facilities that you will be working with to find out where are their pain points, where are they having problems. I think what everyone will notice is that all of us have fairly similar problems across the U.S. Under-resourced, not enough providers, and quality metrics are the ones that are causing most of the problems.
Those are great points. They definitely resonate with me. Taking your idea that technology should be the servant, not the master. And in fact, at Philips, we're moving more from talking about artificial intelligence towards talking about augmented intelligence. AI is augmented intelligence to really help the clinicians be all they can be. And with that, I'll let you get to your last slide.
Yes. This last slide just kind of shows here at Virtual our continuum of solutions. I don't want to spend too much time on that. I want to make sure I see a lot of questions coming through, and I don't know if the moderator can read those out to me. There are a couple of high questions here I want to make sure we attend to.
Yep, absolutely. Thank you, Dr. Server and Dr. Pellegrini, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. Additionally, in the Q&A segment today, we will focus deeper on some of the topics addressed in the presentation. So a lot of great questions are coming in, and I'm going to start with this one. One audience member wants to know, much of critical care medicine is cognitive decision-making. How do you see big data and AI supporting further breakthroughs for critical care medicine?
That is the way it's going to go. I will say the ability for the physicians at the bedside to understand whatever process we are going to embed in our technology of virtual, they have to see the research. They have to they have to understand that it's built upon their own processes. I think from some of the companies I've seen out there, although they may identify a certain risk population, if the bedside caregivers don't understand how that rule came about or what the algorithm was or what the research shows, it won't be bought in. The other issue that I think we're going to run into is there's so many different companies that are claiming to have AI or cognitive capabilities. And so I think as a medical community, we definitively need to understand it better. What does it mean? I think the terms can be used without the true meaning behind it. So I think part of that is just as clinicians, we need to understand what is going to help me take care of my patient better. And I think, I know we're headed that direction. I think tele services will help as long as the visibility is there to the bedside. I will tell people on this call, when we work in that isolation and the bedside doesn't see all of the algorithms and the alerts and how we are doing our processes, we don't get the buy-in when that happens. I did see a question here from Robin about physician engagement is related to budget and lack of payment in this field. Is this my findings? Yes, and this is part of the struggle you will have with embedding tele-ICU or telehealth. The physicians at the bedside and even the nurses at the bedside feel, and not wrongfully so, that they are doing a lot of work and that they should be reimbursed better. And then to see a health system that may want to spend money on another entity of physicians and nurses, that can create part of the barrier that comes in. So really for us in the telehealth field, we need to show that we are not replacing them, and that when you add a virtual entity on top of the bedside, you're getting more than what we call 1 + 1 = 2. You should be getting a much better working environment for those physicians and nurses. Robin, I hope that answers that question.
Thank you so much for answering that.
I'm going to go go through you want me to go through a couple of these high questions?
No.
Yeah, I think that'd be good.
Okay. Yes, Aaliyah?
Yep. The next question that we have is, while you started with ICU, how did you identify the other areas that virtual solutions would provide value?
Most of that came from our collaborative work with other entities and facilities here at the Mercy Ministry. Virtual hospitalist definitively was a need, because same under-resourced, not enough nocturnists at the bedside who are doing anywhere from 15 to 20 admissions, then handling cross-coverage calls, V-stroke, V-mental wellness. There is a paucity of neurologists and psychiatrists across the U.S. to help provide the care. So a lot of it comes from need. A lot of it comes from working with our facilities to find out where would they see more benefit from virtual providers to help them. Jared asked a question here. Are you seeing an increase in knowledge and or exposure with newer physicians from their medical school training? I think we need to do more to expose them to telehealth. If that's what Jared was asking here, we do allow our critical care fellows to get rotations in our tele-ICU, but I think it needs to be part of their training. I think it needs to be embedded in both the nurses and physicians that the future is going to be working physically at the bedside with virtual entities that will allow them to do better at their job. Michael Melby, can you speak to the advantage and disadvantage of having your virtual presence in the main hospital versus offsite like you are? The advantage with being at the main hospital is that you can also leverage your physicians to provide some emergent coverage. So when we started this, we were all housed in our main hospital, and so we did provide codes and intubations, but also were able to manage other sites when we had two physicians on. The disadvantage is that you will be called downstairs to come see patients. You will be expected to do more than just be a virtual physician, and then you start losing the interest of the physicians that are staffing your shifts. You really want to stay true to the goal, which is to be the virtual physician and provide care to remote sites. Once you start double dipping, it can go the wrong way fairly quickly.
So Dr. Pellegrini, I think we're almost out of time here.
Okay.
Sorry to interrupt, but I think I'll turn it back to Aaliyah.
Great. Thank you so much, Dr. Seaver and Dr. Pellegrini, for that excellent presentation. And I want to thank Philips for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you.